Good morning, respected teachers, panelists, and everyone present here. My paper is assessment of biometry and keratometry in low and high degree of myopic patients of Borak Valley. My name is Dr. Rajneel Bhattacharjee of Silchar Medical College and Hospital. Myopia or short-sightedness is an important cause of low vision in the world. Myopia can occur when there is an increase in axial length of the eyeball or when there is increased curvature of cornea. The purpose of this study was to assess the variations in ocular biometric parameters in low myopia, that is less than -3 diopter, and high myopia more than -6 diopter. Various global studies have been done to find the association of axial length and corneal curvature in refractive error, and this study corroborates the results found globally in patients of Borak Valley. In-depth knowledge of the factors influencing the refractive error allows us to plan for appropriate management, like corneal curvature is important for corneal refractive surgery, keratoconus, etc. The aims of the study was to compare the biometry and keratometry values in low and high myopia. A sample of 50 patients were selected aged between 6 to 60 years, presenting to ophthalmology OPD, and divided into two equal groups of low and high degree of myopia. Myopic patients and those giving consent were included, and patients those who had undergone ocular surgery or suffering from ocular diseases were excluded. After proper ocular examination, keratometry and A-scan biometry were measured from both the eyes of each patient. The measurements were carried out in one session by the same examiner for each patient. A verbal consent was obtained from all the patients. Results of measurements were compared in each group, and differences in parameter were defined as significant at p-value less than 0.05. In results, the age and gender-wise distribution, we found that most of the patients were in the age group of 21 to 30 years with slight male predominance. The range of refraction varied from -0.25 to -2.75, with a mean of -1.26 and -1.24 in the right and left eye respectively. And the range of refraction was in high myopia was from -6.5 diopter to -16, and with a mean of -8.66 and -8.36 in right and left eye respectively. The axial length of right and left eye in patients with high myopia had a mean of around 25.85 and 25.59 in right and left eye respectively, and the axial length in low myopia was around 23.64 in right eye and 23 in the left eye. The K reading of right and left eye in patients with low degree of myopia was mainly in the range of 43 to 44.50 diopters. Also, in a high degree of myopia, the K readings in both the eyes of the patient were mostly in the range of 43 to 44.50 diopters. Now, the paired T-test comparison between patients of low and high degree of myopia, we found that the axial length difference between low and high degree of myopia was significant in both the eyes, but the K values of the patients were not significant enough. In this study, 54% were males and 46% were females, and similar finding was in study conducted by Das et al. It was found that high degree of myopia had higher axial length than low degree of myopia, and similar results found in Chen et al., who reported that eyes with more myopic refractive index have error tended to have greater axial length. In this study, there was no significant difference between low and high degree of myopia and corneal curvature. Similar findings were observed in study by Tauzi et al. To conclude, there was significant difference in axial length between low and high degree of myopia. Axial length increases with the degree of myopia. There was no significant difference in corneal curvature between low and high degree of myopia. Hence, axial length has a higher effect on degree of myopia than corneal curvature. Thank you.
Thank you so much. A very nice presentation. All of you have presented very well. Is Dr. Ghosh there? Would you like to ask any question? Dr. Ghosh, Dr. Srinivasa, Dr. Ramesh Babu, Dr. Meenakshi.
Dr. Rajneel,
yes, sir.
Could you tell us what A-scan you had used to measure this one, axial length?
Sir, that is infrared optical A-scan, sir, Metronics, sir. We use that one to measure optical infrared, sir.
And this one for the keratometry reading?
That's Bosch and Lomb keratometer, sir.
Was it a manual or again you had used?
Sir, pardon, sir?
Was it a manual keratometer which you used?
Yes, sir. Manual keratometry, yes, sir.
Did you by chance have, you use this one immersion scan as well as an optical, and did you find any change in that?
No, sir. We actually don't have the immersion that one, sir. So just we used the one we had, sir, in our medical college, sir. Yes, sir.
Thank you, sir. Thank you, Dr. Rajneel. So unfortunately, we will not be judging him because he is a non-ratified AIS member.
Ma'am, ma'am, I'm a member.
In your Dr. Rajneel,
Yes, ma'am.
moderator for this session, can you please see Dr. Rajneel as written as presenting authors non-ratified member?
Ma'am, I'm a member of number is
Ratified and not ratified. Is anyone here who can clarify this? Because we've been asked not to judge 4 of you. There's something called ratification of membership later on, which happens.
Rajneel, if you have your membership number, maybe you can share it with us.
Yes, ma'am. It's
The
B23587.
membership number is written B23857, but ratified. He's I think ratification takes place in 6 months or a year. I don't know about that.
Maybe you just been.
I think Dr. Manisha, we can take this with the technical team, scientific team.
So we've been sent in the email that not to judge the non-ratified members. So we have that. I think we can keep our scores on another piece of paper. If they ask for it later.
Correct.
Thank you.
Yeah.
Next person. This is
Thank
Dr.
you, ma'am.
Ankush Tinna.